Welcome, everyone, and thank you for joining us. Today, we're going to explore one of the more sensitive issues families face when someone's diagnosed with genetic FTD. We're fortunate to have three wonderful speakers with us today. Community members Wanda Smith and Ansel will be sharing their approaches to talking to family about genetic FTD. And we'll also hear from Angela Lunde, Associate in Neurology in the Alzheimer's Disease Research Center at Mayo Clinic in Rochester. Angela will provide tips and strategies for navigating challenging family conversations. I'll introduce each of them as we move along, but I wanted to take a moment now to recognize and thank them for sharing their perspectives. Although today's webinar focuses on genetic FTD, the tips and strategies we'll cover are useful for all families affected by FTD. Adult onset neurologic conditions, especially those involving cognition, carry a unique stigma, one that's often greater than what's seen in other conditions like ALS, cancer, or cardiac disease. This stigma leads to feelings of shame, making conversations about FTD particularly difficult. Families may avoid the topic out of fear of causing distress, while relatives less directly involved may be reluctant to face the reality of FTD. Alongside stigma, shame, fear, and denial, families also want to protect one another from painful truths and hard decisions. The confluence of these varied emotions can make conversations about FTD and genetic FTD especially stressful and overwhelming. Now, before we get started, I have just a few quick announcements. We've muted our audience to minimize background noise. AFTD staff are working behind the scenes, and they're available to help you if you encounter any technical issues. Just let us know by writing a message in the Q&A box. Time permitting, we'll answer questions at the end of the webinar. You can use that same Q&A box to submit your questions. And if you want to submit a question anonymously, just click the box to the left of the send button. Please feel free to submit your questions at any time. You don't have to wait until the end of the webinar, and we'll get to as many questions as we can. And finally, this webinar will be recorded and archived for later viewing on AFTD's YouTube page and in the webinar section of our website. Next slide. We know that not all FTD is inherited. For the majority of people diagnosed, FTD appears to be sporadic. We don't yet understand how or why FTD develops when it seems sporadic. The presumption is that relatives of somebody with sporadic FTD do not have an increased risk. However, we know that 5 to 10% of people with apparently sporadic FTD do have a genetic cause, even in the absence of any known family history. In roughly 40% of people diagnosed with FTD, there is a family history of other relatives with FTD, or perhaps related conditions like ALS, or a psychiatric or another dementia diagnosis, or maybe they're having problems with movement or language. When FTD and these related conditions are clustered in the same family, we refer to this as familial FTD. And when FTD is familial, we're generally able to identify a genetic cause in about half of these families. When the genetic cause is identified, we refer to this as genetic FTD. And overall, about 20%, or 1 in 5 people diagnosed, have a genetic form of FTD. Next slide. The 3 genes that are most commonly associated with FTD are chromosome 9, open reading frame 72, or C9orf72, microtubule-associated protein tau, or MAPT, and GRN, which is also called progranulin. C9orf72 is the most common cause of genetic FTD and genetic ALS. And along the bottom in pink, you can see some of the less common genes that can also cause FTD. Many also cause ALS and sometimes other symptoms. And there are more genes that have yet to be discovered, as we're depicting here in gray. Most of the genes you see here can present with any of the symptoms associated with FTD. Again, this means in one family, you might have a person with behavioral changes, but another relative might be having problems with movement or struggling with language. And this contributes to people, including health professionals, not recognizing a pattern of inheritance in the family, and this in turn contributes to difficulty in getting a timely and accurate diagnosis. And this highlights that while family history is important, it isn't always obvious when considering if FTD might be genetic. Genetic forms of FTD tend to follow an autosomal dominant inheritance pattern. This is particularly important to understand when we want to consider the implications for relatives. Dominant inheritance means men and women are equally likely to develop FTD and equally likely to pass FTD on to the next generation. And some of the genes are highly penetrant, meaning a person with an FTD-causing variant is likely to develop FTD. With dominant inheritance, a person is at risk for FTD when just one copy of an FTD-causing gene has a pathogenic variant, what we used to call a mutation. With dominant inheritance, FTD may be present in multiple relatives across generations. And when there is a confirmed genetic cause, the children and siblings of a person diagnosed have a 50% or a 1 in 2 chance to also be at genetic risk. Next slide. AFTD recommends anyone with a diagnosis of FTD should be offered genetic counseling with the option to test. When a person has symptoms, this is diagnostic testing. And diagnostic testing can help confirm that the diagnosis is accurate. Sometimes it informs aspects of care, and it allows families and physicians to anticipate future care needs. A genetic diagnosis may also open up opportunities to participate in clinical trials exploring a potential treatment. And it also helps families understand who else may be at risk to develop FTD. However, when a person has no symptoms but is considering testing to see if they've inherited the family's FTD-causing genetic variant, this is predictive testing. And predictive testing allows a person to understand if they're at risk to develop FTD at some point in the future. For some people, the anxiety of not knowing weighs heavily. And for some, having that knowledge helps them to plan for the future. And hopefully, it'll make an accurate and timely diagnosis possible with quicker access to services if and when symptoms do develop. In many instances, knowing one's genetic risk is a motivator for people to participate in research. But the decision about if or when to have predictive testing is challenging, and it should be considered carefully. Genetic testing is not right for everyone. The decision about genetic testing has implications beyond the individual. Other relatives may have very strong feelings about testing, and you need to keep in mind that one person's results could reveal information about other relatives. It's always wise to consider your options and your family's circumstances and to learn as much as possible prior to deciding about predictive testing. Next slide. Next slide. When a family understands FTD is genetic, they need to decide how to share that news with relatives. Who do they tell? And how do you share such sensitive and impactful information? These conversations can be complicated. Some relatives may prefer not to know. Sometimes they may question the validity of the information you're sharing. Relatives may react with skepticism or even frustration and anger towards you as you deliver the news. We can all appreciate that even under the very best of circumstances, family dynamics are challenging. When we add in genetic FTD to the mix, all of those challenges are amplified. So from here, I'd like to introduce our first guest, Wanda Smith, who will share how she has navigated these sensitive conversations with her own extended family. Wanda has worked in the realm of dementia advocacy and awareness for over 40 years. She's an assembly member at the California Senior Legislature. She has led efforts to pass California's 2024 FTD Awareness Week resolution and pioneered a day respite program. And for her decades of advocacy, Wanda received the 2024 Visionary of the Year Award from the Alzheimer San Diego. And in 2023, she was presented with a Rare Voice Award from the Everyday Life Foundation for Rare Diseases in recognition of her statewide advocacy work on FTD. We'll hear from Ansel directly after Wanda's presentation. Wanda and Ansel have both pre-recorded their stories, and we have edited them for length, but we kept all of the relevant content intact. So what were some of the biggest challenges that you faced during the process of trying to get an accurate diagnosis for your mom?
Oh, it was maddening. The first doctor looked at her eyes and nose and ears, and he said, "Yep, you've got Alzheimer's." And I said, "Oh, she's standing there." We said, "What do we do?" And he's like, "Nothing." He said, "Next patient." We were out the door. The next one was very similar. And then we had a lovely uh, neurologist who was a little kinder and gentler. And when my mother said, "It can't be that," I know it can't be that. He said, "Well, let me have the nurse check your blood pressure one more time." And then he went on to describe what Alzheimer's was. And that was in 1982. And then about 4 years later, I'd had my second child and was expecting my third. And Life magazine decided to come and visit. And they were there for 2 weeks doing a profile story, and I didn't want to do it. How do you get up at 6 in the morning with Life magazine and till 6 in the evening? And but we did it, and they were very gracious to my family, and the images really showed what caregiving is all about and what it's like to have a young family and navigate that journey. And that was the first actual article that came out in 1986 that profiled Alzheimer's and brought it kind of into the spotlight of a real disease and a real issue for families.
Wonderful. So really groundbreaking. And at the time, we were only just beginning to recognize that Alzheimer's was a form of dementia and gave it a name. How did you finally get to the diagnosis of FTD for your mom?
Well, we did an autopsy, which was kind of rare back in those days. She passed away in 1987. And because of my relationship with UCSD and Dr. Bob Katzman, we had started a brain bank here in San Diego area. And so it was a bit of a surprise when I had the meeting with Dr. Bob Katzman, and he said, "She has no plaques and tangles." And I said, "Whoa, everything is plaques and tangles. That's what Alzheimer's is." He said, "Nope, she doesn't." And so that began a collaboration with him. Are there other family members? And I said, "It's a big family. Sure, there's other family members. I don't know who's sick and who's not." But he said, "Have you ever done a pedigree?" And I said, "No." So we were out to dinner one night, the two couples, and he drew on a napkin what a pedigree was. And that began the journey of identifying. My mother had 58 cousins. And so that was the first step. And along that step was to look at the lineage. The family was, they originated in, they were European-based family. And so I was able to identify 15, it's now, I think, 19 generations of the pedigree. But her 58 cousins were incredible. And we always referred to the family as having it. It really didn't have a name.
Now, with 58 cousins, I imagine they're spread across the country. How did you coordinate everything?
Telephone, this was actually, it's hard to believe it was before the internet. So telephone calls and traveling, different scientists were very interested in different families that lived near them. And then we became very good, actually, at doing family reunions. And scientists would show up and draw blood. And as different family members passed away, they too were very generous. So I've always kind of thought of my family as being just a very generous group of people. Um, Science is not something you really think about, but in my family, they really wanted to get to the bottom of this. And so that was in 87 that my mom died. And then in 2006, that had been 18 years, the identification of the progranulin gene was identified through Rosa Rademacher, and Alison Goat identified the particular mutation and that my family had. And now fast forward, it's an additional 18 years, and now we have clinical trials. So it's been a
Wow.
wild journey.
It really has. So what was it like learning that your family's participation helped researchers identify the GRN gene?
Oh, it's just kind of a pinch me moment, you know. When you
It's
know that your
critical.
family, yeah, and all those samples that were, you think they were given in a rural area or a urban area, but they were duplicated and replicated and shared across the globe. And so it's quite funny when they have a mouse model, and I kind of know that the plasma was a part of that, or the skin biopsies or the spinal fluid. So yeah, it's a pinch me moment.
So now with 58 cousins, and I can only imagine how many other more distant relatives you have, was everybody all on board all the time doing all of the research? They were eager to hear everything that you had to tell them, or were there some people who were maybe a little more reluctant to hear about FTD?
Well, it's a big topic, and
Mhm.
it's a little intimidating for people because it's science, it's biology. Most of us, we have doctors in the family, we have lawyers in the family, and it, even with a higher educational level, it's still hard to kind of wrap your brain around and understand. So I tried to do breadcrumbs. I created family newsletters that were quarterly, that would spotlight different scientists, would spotlight different parts of the pedigree. Um, at that time, All FTD was started. There was Lefties and Artful, and then it became All FTD. And so encouraging family, I would talk a lot in the newsletters about how they could get involved, and just bringing breadcrumbs, little bits of knowledge that they didn't have to go out and look for information or knowledge. I could bring it to them in a very easy format. So that was good. And I could tell some of them didn't want to hear about it at all. And some of them, I could do like the fire hose of information, and they wanted to learn more. So over time, different people have changed, even those who didn't want to know are asking questions, because the health of a family is important. And the AFTD has done a wonderful job of having support groups, having you've done the genetic counseling piece, and getting information out to really help families put this in context, that it really matters.
Yeah, I think you raised a good point that there are people who don't want to hear about it. And it's an emotional subject to hear that this is the cause of the changes that you're seeing in your loved one. It could potentially happen to you. So when people respond negatively to your breadcrumbs, what approach do you take? Do you continue to try to feed them the breadcrumbs, or do you back off? I mean, how has that worked for your family?
I think it's just little by little. Most people are very kind, and no one's really shut me down totally. But you know, these are family. You love them, and you kind of know, okay, that's enough. No more talking about that. Let's talk about your kids. Let's talk about your life, other things that are going on. So
Sort of
it's
read the room.
navigating, yes, navigating conversations, it's navigating knowledge, it's navigating the fear that people have, because it is a very frightening. Our culture has made a lot of the dementias, neurodegeneration, to be a really a negative thing. So trying to understand that, and I guess life is like meeting people where they are. And if we can meet people where they are and bring them a little information, when they want more, they'll come back and ask for it. So, and the good thing is that because our family's been so involved, these clinical trials are wonderful because it's an opportunity for my family to participate if they want to, and then to, see how these clinical trials are affecting other family members who have symptoms. Maybe they don't have symptoms, but we get a front row seat at how these drugs are actually working in the lives of those that we love.
Okay, thank you. Thank you, Wanda, for sharing your family's long history and tireless efforts to help identify the GRN gene as a pivotal cause for FTD. Next, we'll hear from Ansel Dow, who will share his approach to relatives as his own family came to recognize that FTD in their loved one was genetic. Ansel's relationship to FTD began at birth when he inherited a pathogenic variant in the MAPT gene. After his family's story was shared in the New York Times piece, The Vanishing Family, he began to advocate for development of new treatments for MAPT with the organization Cure MAPT FTD. He lives in North Carolina, works as a biomedical engineer, and Ansel likes to host dinner parties. So please help me welcome Ansel.
The conversation in my family has been going on for a long time, since I was very young and before I was involved in those conversations. And there are some members of my family who have been very, very open and receptive to discussions about genetic risk and the risk of asymptomatic folks in the family for the disease in the future. But there are other family members, some of my aunts and uncles, who really were uncomfortable with those conversations, or even dismissive, even not really willing to acknowledge that the disease exists. And this was several years ago, while those symptoms were still sort of hard to define and didn't match very well to any diseases that folks were familiar with. Because it is so different from Alzheimer's. Behavioral symptoms are sometimes really difficult to articulate and could be confused for other things, for non-neurological conditions. And that caused some pretty serious rifts in the family. An uncle who just said, "I don't want to talk about this. I'm not willing to engage with this conversation." And some other family members who felt very alienated, or who really just broke off contact with the family. Yeah, and that's been difficult. Even talking about it with folks who are pretty much close to on the same page, it's still a hard thing because it is so emotional and because it involves such kind of tangled personal issues. I think even in those situations, it's not easy, but it has felt really special to be able to identify places where we do feel the same, and hopes and fears that we share and can share about. This has really been a process taking place over years, where folks that originally felt very uncomfortable discussing it all sometimes will begin to acknowledge, like, this is a problem, it's not going away. And even if they maybe still don't feel comfortable discussing the details, they'll participate in some ways. Maybe they're a caretaker for someone with symptoms, and so just in their day-to-day, that it's a concern for them. Or maybe they have kids that they want to discuss risk with, and that's the starting point for the conversation. Yeah. In one of these cases, my uncle, who was never really open to speaking about FTD, and who was married and had kids, and kept their family pretty separate from the rest of us. My uncle eventually developed symptoms, and his wife reached out to the family, even though she had never had very much of a relationship with other folks, to say, "Hey, I do think that the same thing is happening, and now we're looking for resources and looking for maybe testing options," which, yeah, it's hard, and sad that it happened that way, but that was a moment where we could say, this is something we've gone through before. It's this very unique experience that we share, and it's something that we might be able to help each other out with. Well, my aunts in this case, who went through a really difficult divorce, as she really had developed some pretty substantial symptoms, but her husband and her husband's family was not aware that she was affected by the disease and just felt that she was acting in this really selfish and kind of dishonest way. And eventually they were totally they didn't want any contact with our family after that, which I understand just because it was a difficult situation they were going through. They felt really a lot of fear for my cousin, my aunt's son. And I was just recently able to reconnect with that cousin because he hadn't had any contact with our family for 15 years, and share a little bit more about the disease and what role it might have played in this messy, difficult divorce. And that felt like a really healing moment. And he was really open to hearing about it and understanding, because there had been, many years to settle, to feel a little bit more grounded and to come together from a place of trust and openness rather than kind of defensiveness and fear. I've had one or two conversations with relatives who I'm hoping will get more involved in research and advocacy, and who will maybe consider testing. And that's the point where they say, no, like that's too much for me, and that's not a place I'm willing to go.
Yeah.
Yeah, and I think, oh yeah, one that happened in this past year, I really felt pretty positively about our interaction because I was able to kind of see where he was at and understand that's as far as he wanted to go, and know that, like, if I push farther, if I keep pushing on this, I don't think it will get us anywhere, and it will harm our actual relationship. It will, erode some of the trust between us, and say that I can just leave it at that. And it's something we'll talk about a year from now. It's something we'll talk about 5 years from now. And that I do think it's worthwhile to try to plant those seeds and say, this is something that I care about and I would like to follow up on. But I'm not gonna demand that of you. I think that could be a constructive way to approach it. Advocating for development of FTD treatments is something that's so important to me, and also combining that with the real challenge of navigating family relationships. That's just a very potent combo, and it's something that I don't always have the energy or the capacity for. And really, speaking with people who I'm not related to about FTD, 90% of the time, it's much easier. I feel like we can connect and we can find things that we have in common, and it's not as energy intensive. And so getting connected with a community of FTD families, of other genetic families especially, has been a really wonderful thing. And I'm able to, see those same challenging dynamics playing out in other families and say, you don't want to talk to your cousin? I'll do it because it'll be easy for me. We'll be able to sort of approach each other as strangers and start from there rather than navigating all these complicated webs of family stuff. And that's really been lovely to have some new perspective on just how important it is, and how many really constructive options there are for engaging with FTD, that are sometimes easier to do with people you're not related to. That's been a really special thing, and get to introduce them to my cousins and my brother, and show, like, this is not something that we have to navigate with just our family. It's not a problem we have to solve ourselves. And it's not a problem we could solve ourselves. There are a lot of other people out there in very similar situations. And after so many decades of having it be kind of a secret or something that, I'm not able to share with anybody, it feels really wonderful to be able to tell those stories and say, this person knows what it's like to grow up with a parent with FTD, or to have a positive test result kind of looming over them. And that's not something that I have to kind of carry on my own.
Yeah.
And really, I think it's so important to do that in community with other people from FTD families, because I've got a lot of really wonderful friends in my life who I've shared with about my experience, growing up when my mom developed symptoms and my fear for my own future. But it's a complicated story to tell, and it, it's just not the same as talking about it with someone who's been through the same thing, someone who's been a caretaker. There's just so much sort of little there's context there that is so difficult to describe in a way that is kind of substantial and has the emotional weight that it deserves. That being able to share that with folks who already have that background, that context is really special. While there are no treatments available for FTD right now, there are plenty of reasons to feel optimistic and hopeful. There is research that really could lead to substantial development and treatments in the very near future. And that's something that I bring to conversations with my family members, saying that this is not a dead-end situation. This is something that we can work on and we can make a real difference for if we put our minds to it. And I think that some of my relatives have felt for many years that there is nothing to be done. I felt that way for a while, and I don't anymore, because I see the impact that patient voices make and that FTD families make when we speak up and we tell our stories and when we say this is urgent, it's serious for us, and we want treatments to be developed. Yeah, I think that's just a critical ingredient here, because it does matter that we think about this and we talk about it.
Thank you, Ansel, for sharing your very personal story of how you and your family have navigated these difficult conversations so sensitively with extended family. It is now my pleasure to introduce Angela Lunde. Angela is an associate in neurology in the Alzheimer's Disease Research Center at Mayo Clinic in Rochester, Minnesota, where she leads the Outreach, Recruitment, and Engagement Core and the Care Research Division. Her passion and work include those impacted by FTD. Angela has spent her career alongside people living with dementia and care partners who have mentored her towards an empathetic understanding of the lived experience of dementia and the role of caregiving. Her research focuses on emotional and quality of life factors and understanding the outcomes that matter the most to those living with FTD and their families. Angela co-authored the Mayo Clinic on Alzheimer's disease and other dementias, and authored the book Day-to-Day Living with Dementia, a guide for caregivers. Ms. Lunde has training in mindfulness-based therapies, including mindfulness-based dementia care, grief and loss, wellness coaching, and dignity therapy. Okay, Angela, thank you.
Great, thank you. So just quickly, are you seeing the slides as they need to be seen? Can you hear me? Yeah. All right, just wanting to make sure that I'm being heard.
You're good, Angela.
Oh, great, thank you so much. All right, well, a pleasure to be here. Thank you. So I'm just going to start out with just a little bit of background, and really, first and foremost, I'm not a genetic counselor, but I think it's important to know that for over a couple of decades now, I have built relationships with thousands of caregivers and families that have been impacted by neurodegenerative diseases, including frontotemporal dementia, including members of my own family. And my mentors, my teachers and guides, and I would include those individuals, and I would include Wanda and Ansel in that, have shaped my understanding of the lived experience, have shaped my understanding of the truth of stigma, what really matters, where the pain points are, how to overcome day-to-day challenges in a way that protects one's well-being. So in the 20 minutes or so that I have with you today, what I want to focus on are these strategic the ways that we can strategically communicate that supports the difficult conversations that I know families are facing. So when you think about genetics and genetic healthcare, it involves the decision by one or more family members or relatives to undergo genetic testing. And if they are the first person in a family identified with a particular genetic disorder, they're often referred to as the proband. And so now comes this complex decision about what to do with that information, including who to share it with, when to share it, what exactly to share, and how to communicate it. And the how to communicate it and how best to navigate these sensitive discussions is what I hope I can offer some thoughts on today, because these are sensitive discussions and decisions, and there are oftentimes a lot of strong opinions. But overall, some of the research into familial communication suggests that patients or probands who know genetic information often believe that it is their responsibility to inform relatives of any relevant genetic information, and to do so because they want to give them the opportunity to make decisions that they could not make without such communication. But here's the thing, and that is that families are entangled, they are complex with years of shared history and expectations and emotions. And communication is not only a very powerful element to family relationships, it can be one of the hardest to get right. When I think about what successful family communication is and how it's impacted, I would say it's dependent on a number of factors, including family dynamics, which for some may include strained relationships between family members. There will undoubtedly be differing perspectives amongst family members based on individual values and beliefs and experiences, individual coping styles. And it can get even more messy, as I think you heard from Ansel that and Wanda, that the ability to give and receive complex genetic information is, well, difficult to say the least. Every family develops unique communication habits and skills, and they're shaped by these unspoken rules that families have, emotional dynamics, individual roles that family members have within their families. And these all influence how family members communicate and how they manage conflict. I know most of us here listening today probably understand the benefits of sharing genetic information, probably because we believe that knowing genetic information about one's risk can inform decisions that we would not be able to make without such information. But for some, knowing the genetic results, even if it's a positive variant, is less distressing than living with uncertainty. Knowing about genetic risk can help families better interpret future changes because they might be noticing some early symptoms of disease onset. And knowledge can be empowering. It can be a catalyst to have conversations around future planning. It can motivate a focus on lifestyle factors that can support general health. It can impact early intervention, which is more likely to provide greater opportunities for management of the disease, greater opportunities around emotional support, research participation, advocacy, and hope. But we also know there are reasons why people don't want to know this information, or we know that there are reasons why we may share sharing information or delay sharing information. And I mentioned a couple of times already that this is a complex topic, and understanding how genetic tests work and their predictive power and the actions one can take, and what and based the actions one can take based on results is not only complicated, but it goes without saying that not everyone will agree. We know that there's an emotional weight here, anxiety, fear, worry, particularly for those who might feel responsible about how genetic conditions can impact their children. And for some, knowing the results may be more distressing than living in uncertainty. So finally, the struggle can go around just the impact that these results might have on one's lifestyle, stigma, discrimination in areas of employment, insurance, and choices around family planning. So that's just to really set the stage that these are complicated conversations. Navigating these conversations is difficult. I'll just say, that there's not any right or wrong way to do this. As you heard from Ansel and Wanda, you heard some things that each of them did because of the situations in their own families. But as I mentioned, focusing on successful communication is oftentimes goes down to a lot of the things that we can do in terms of how we communicate and the skills that we maybe bring with us in the ways that we communicate. I want to, when I listened to Wanda and Ansel just now, I think I heard two overarching themes that came from both of them that I think and I believe are really the critical ingredients for having family conversations around genetics and FTD. And that is that both of them, as you listen to them, chose to come from a place of empathy. And they talked about planting seeds and sprinkling breadcrumbs. And when I think about what that means, and they shared a little bit about this, they talked about planting seeds as meeting people where they were at. And that starts by listening to understand where people are at and what their unique perspectives are. I think when we're really focused on planting seeds, we're focused on creating a space for understanding, creating a space for future discussions. Because if the person isn't ready to have that discussion or maybe isn't developmentally mature, you don't need to share everything all at once. Sometimes seeds need some roots to grow right away, and sometimes they need to stay dormant or quiet for a while before they start growing. I talked that both Ansel and Wanda really brought empathy into the equation. And I like to talk about empathy first by talking about what empathy is not. Empathy is not agreeing. It is not taking someone's side or backing down or giving in. You don't need to have shared values or beliefs to empathize with somebody. But empathy is perspective taking. It's stepping into someone else's shoes as best you can and trying to really understand what's going on for that person and doing so with curiosity and openness. Empathy is listening to understand rather than to reply or to debate or to convince somebody. But empathy is a powerful tool for building bridges and navigating difficult conversations. With planting seeds and empathy as the foundation, let me go a little bit more deeper into some of the ways to consider navigating these difficult conversations. And I'll first talk about some things that you may want to do even before you have a conversation. Sometimes just thinking about timing and location can impact the outcome. So choosing a suitable time and place that minimizes distractions and allows for a more focused discussion. I also recommend that you start with the end in mind, knowing the outcome that you are seeking. If you're not clear in your own mind about where you want this to go, the meeting can become derailed very quickly and get off track. So you can ask yourself some key questions, such as, by the end of this conversation, what information do I hope to share and what outcome do I want? What do I need to understand better? Be patient and remember to be open to outcome, not attached to outcome. You can plant a seed, but I think as Ansel said it so well, you can't force it to grow. Also, be prepared with the message and the information that you want to share. And of course, it's important to tailor it to the person, to their age, to their level of development. But you may want to share why you believe it's important to communicate this information to them and why it was important for you to know more about FTD and your genetic risk. And you may want to have some information on hand. Maybe it's information from AFTD, maybe it's a copy of your own genetic report, or perhaps, your doctor or your genetic counselor prepared a letter for you that describes genetic testing and why it might be relevant for them to know this information. The key is to think about giving information rather than giving advice. And I think this is important to sort of underscore. There's a difference between giving advice or recommendations or suggestions. There's a difference between giving advice and giving information. And that is the difference between giving advice and giving information, is that giving information is not telling somebody what they should do, but rather it is offering data to inform their decision. The other thing I'd say before the conversation starts is that a successful outcome will not only depend on what you say, but on how you are. So checking in with yourself, notice really where you are around this situation. Are you triggered or angry or in a defensive mode? I think some of us approach difficult conversations like a debate rather than an opportunity to gain and to share knowledge. What is your perception of how you want the conversation to go? If you think it's going to be horribly difficult, then it probably will be. If you truly believe that whatever happens, something good will come out of it, then that likely will be the case. So try to adjust your attitude for maximum effectiveness. I sometimes talk about taking a mindful pause before you start the conversation and check in to determine your intent. If you are centered, supportive, curious, open to understanding a different point of view, and believe that something good is going to come out of it, things will go better. Once you're starting the conversation, there's no real specific way you have to start a conversation. Check in and just start it in a way that feels right for you. But a couple things I would say is weaving I statements into the conversation. And an I statement is a manner of talking in which you only speak from your point of view. It never assumes that what the other person might be thinking or feeling. For example, rather than saying, you need to know this information, you can say, I truly believe the information I am going to share with you will be valuable because it can inform decisions. Share your information. So, I want to share some, you may say something like, I want to share some information with you that I think can help our family now and into the future. I hope to answer any questions you might have, but more importantly, I hope to better understand what you are thinking and feeling. So those are just some ways I think that can start a conversation in a way that's open, not from a defensive standpoint, not from a standpoint where you're trying to convince. And once you open that up, once you share your information, then the skill of listening, really listening, comes into play. When we talk about empathic listening, often we do not listen with the intent to understand. We often listen with the intent to reply. But listening to understand may be one of the most productive things that you can do when navigating a difficult conversation. So there's two sides. Let's talk a bit about empathic communication and listening, because it is a skill. It's the ability to understand another person's feelings by actively listening and trying to see things from their perspective. Active listening means listening to understand rather than respond. It means maintaining eye contact to show that we are genuinely interested in what they have to say. It means refraining from interrupting, because when we cut people off, not only do we interrupt their train of thoughts, but we miss the opportunity to truly understand their point of view. And empathic listening means avoiding judgments, because one of the pitfalls to empathy is making quick judgments or assumptions about another person's intentions or character. Somebody may be dismissive or argumentative or agitated or angry. You may sense fear or shock or confusion, and these are all normal emotions and to be expected. But in empathic communication, we don't judge, but rather we make it safe for people to feel what they feel. So empathic communication is not only listening, but it's also key to it is how we respond. And I just want to quickly share three ways of responding that I think really can be a game changer in how these conversations go. Using open-ended questions. So open-ended questions are considered the gold standard of communication and building blocks for connection. They show curiosity, they convey an interest in what others think and feel, and they can make the person feel less guarded since they are less likely to perceive that this conversation is bound to somebody else's agenda. We're asking, in asking open-ended questions, we're demonstrating to others that we value their story. Open-ended questions sound like, can you tell me a little bit more about that? What are your thoughts about what I have shared so far? Or how does this make you feel? Empathic reflection involves repeating back what you've heard the other person say. It demonstrates that you're paying attention. You want to make sure that you've heard them correctly. So for example, if a relative shares with you that they're angry because you decided to have genetic testing without their knowledge, empathic reflection might sound like, I can see your point of view. I understand you feel angry that I made the decision to get tested without your knowledge and that it is putting a lot of stress on you. Reflecting what was said to you makes the other person feel heard. And by saying, I can see your point of view, it might sound like you're agreeing, but you're not. You're understanding. Most important, you're demonstrating that hearing them is important to you. And the last approach I would recommend is validating feelings. There's a saying, never meet a feeling with a fact. And it's a phrase we use to talk about acknowledging, validating feelings. Validating feelings for me, I believe, is at the fundamental cornerstone of all human interaction. Validating another person's feelings shows care and concern. And often the mere act of staying back or validating or naming somebody's feelings begins to bring immediate relief and ease. And you don't need to agree with somebody to validate their feelings. Validating feelings sounds like, it sounds like this. It sounds like you're feeling really overwhelmed by everything that's happening. Or I can sense your frustration with me and this situation. Or I know you feel worried and scared right now. These responses show empathy and they encourage the other person to keep sharing and they build up relationships and trust. So now that you've heard some things around empathic communication, I just want to end by saying difficult conversations, even when you are armed with these skills, are still difficult conversations. Don't take it personally if they don't go well. Sometimes you need to take a pause, perhaps end a conversation that's not going well, or allow some space between you and other family members. Be patient and know that you have planted some seeds or sprinkled a breadcrumb or two. Provide the resources and support that they may need. As Wanda mentioned, that may be a newsletter, but providing the support and resources they need to continue to grow rather than to force a specific outcome on them. You may want to consider a third party, a counselor, an informed healthcare provider. I loved what Ansel said as an FTD advocate. He's even offering up himself to have conversations because sometimes these conversations with somebody who's a bit more of a stranger can go better. Lastly, I would say was to recognize that you only have control over yourself. As much as we wish we could control others around us, we cannot. Recognizing that decisions around genetic information are preference sensitive. We may feel all sorts of feelings about what's being said or done. I often tell the families I work with that feeling bad about something is not the same as being responsible for it. Knowing you did the best you could with understanding and with empathy goes a long way in helping you remain emotionally healthy and at peace. So thank you for letting me share.
Thank you so much, Angela, for sharing your valuable and sensitive perspectives, expertise, and the strategies for these challenging conversations. I loved what you said about listening to understand and being open to the outcome, as well as sharing information rather than advice. I think now I'd like to just take a moment to try to recap some of the take-home points from everything that Wanda, Ansel, and Angela shared today. Each of them emphasized the importance of approaching these conversations with empathy, respect, and genuine curiosity, meeting each person where they are. When somebody's ready, they'll be open to listening. But if they're not ready, give them time and space. Allow them to come to you when they're ready to engage. As Ansel mentioned, and I think also Wanda, try to create non-threatening opportunities for them to connect with you without the pressure of talking about genetics or FTD. It's important for you to be seen as a safe person for them to talk to, even if their initial reaction was negative. Wanda shared how she developed a family newsletter. Using written materials like a family letter is wise. It gives people the option to read or not, or perhaps they can put it aside for if and when they're ready. Both Ansel and Angela mentioned involving a neutral third party, like a therapist or a genetic counselor, or Ansel himself. A neutral person can help to ease some of the pressure and allow you to play a more supportive role to your relative. Remember, this is very personal, and your experiences may look very different. Their experiences may look very different from your own. Your urgency may not be their priority. Over time, they may come to realize that this is information that they need, and they'll know who to turn to as long as you remain safe and open to them. Next slide. So over the past few years, AFTD has been developing educational resources to help families feel more prepared when confronting possible genetic FTD. These include several webinars addressing concerns prior to and after testing, and several printable resources to help families understand everything from privacy issues through research participation. Next slide. Next slide. And of course, we want to make sure that you're all aware of our genetic support groups. We offer 2 support groups specifically for asymptomatic people who know FTD is genetic in their family. And we have maybe a minute for a question. Let me see. I'm just going through our questions here right now. So one question that we received was, can children of someone diagnosed with genetic FTD who do not develop symptoms be a carrier and pass FTD on to their children? In other words, can FTD skip a generation? It's a really good question. It's a nuanced question. I'm not sure I have time to answer it today. FTD does not skip a generation, but there are certain genes that are less penetrant. And we know that there are other genes that can interact with FTD genes that can alter how penetrant FTD is. So penetrance is referring to the likelihood that somebody with a pathogenic variant will develop diseases. And with FTD, particularly the genes that we know so far with FTD, not all of them are 100% penetrant. They have what we call age-dependent penetrance. So the older you are, the greater the chance for you to develop symptoms. But that being said, not all of these genes are entirely penetrant. And there are some people who can have a pathogenic variant in an FTD gene and never develop symptoms, or may develop symptoms very, very late in life. So it's not that it necessarily skips a generation, but it may not be obvious in prior generations. I don't know if I answered that question yet. Are there any other questions? I think that we are at 3:59. So I'm sorry, we won't have time to answer any other questions. This wraps up our webinar for today. Thank you again to all of our presenters, Angela, Ansel, and Wanda. Although we can't answer everyone's questions, please remember you're not alone. The AFTD helpline, excuse me, is another great way to get advice, support, and the resources you need. So this concludes our webinar. Please let us know if you have any comments or questions about today's presentation, and we'll follow up with an email to each of you, including resources and links to replay this webinar. Thank you so much.